obnašati, a sad mi je čast i zadovoljstvo najaviti docenta Uroša Babića iz Beograda i Srbije, koji će nam prikazati svoju prezentaciju pod naslovom Direktna terapija metastaza kod raka prostate. Evo, izvolite kolega.
Good afternoon, dear colleagues, and first of all, I would like to congratulate Professor Perović for organizing this fine meeting. I suppose that the majority of us from Serbia prefer this meeting, and we enjoy being here in Budva in Montenegro, and it's also a great pleasure to be here with Professor Stencel and all other distinguished colleagues. My name is Uroš Babić. I work in Clinical Center of Serbia. That's a high-volume center, and we certainly have a lot of experience with the treatment of prostate cancer. But this lecture is about something which is not conventional medicine. It's a relatively new thing, and it's a pretty much alternative thing. I'm actually talking about the patient in the middle, and that's the patient with the oligorecurrence, which means that this patient previously underwent surgery, radical prostatectomy, or radiation therapy. And with whatever imaging we use, we find the different spots, and these spots, that's the question, what should we do with them? Metachronous oligometastatic disease refers to the development of few metastases after the primary cancer is treated or detected, and the term oligorecurrence describes the development of metachronous oligometastasis with a controlled primary site. Oligometastatic prostate cancer generally is defined by presence of 5 or fewer metastasis sites on imaging, and it actually represents a transitional state between localized and widespread metastatic disease. In 1995, Hellman and Weichselbaum hypothesized that the eradication of these oligorecurrences with MDT, metastatic directed therapy, might prevent additional spreading of disease and improve survival. And several retrospective studies have supported the notion that MDT delays additional clinical progression and start of subsequent palliative androgen deprivation therapy with minimal adverse events. However, such an advantage has yet to be shown in well-controlled randomized studies. We actually don't know what is optimal scenario or optimal treatment for this kind of patients. This is Ralph Weichselbaum. He used to be director of Chicago Tumor Institute and head of University of Chicago Center for Radiotherapy. And you probably know story about him when they asked him why 5 metastases are considered to be oligometastatic disease. He said, because I said so. So we actually don't have consensus. Are 2, 3, or 5 metastases are oligometastatic disease. We need some kind of molecular characterization. This diagram demonstrates the metastasis-directed therapy management options for patients with oligorecurrent prostate cancer. So if you have positive lymph nodes after previous therapy, then you can consider to do surgery, lymphadenectomy salvage, or radiotherapy with wider fields of treatment, or for bone metastasis, SBRT, or for visceral metastasis, which are rare and we have limited evidence for this. You can think about surgery or systematic treatment. Approximately 50% of the patient we treated previously with operation or radiotherapy will at some point have a rising of PSA recurrence or biochemical recurrence. So if you have biochemical recurrence, everybody says do PSMA PET-CT. So what if you do PSMA PET-CT early? There are numerous trials on looking where the spots are, and faster you do the imaging, probably you will see a lower volume of disease. On those two studies, and on the left side you have when you use Holin CT imaging, and the majority of recurrences will be in the pelvis. And on the right side is when you use PSMA PET CT. That's pretty much the same thing, and a lot of recurrences will be again in the pelvis, and about 20% of them will be distant. And so it's important to if you do PSMA early, you can almost predict where the recurrences will be, and to think about what kind of a therapy can you do in future. Here is summary of evidence from guidelines, and we have a strong recommendation to use PSMA PET-CT or Holin PET-CT for patients which are fit for curative salvage treatment. One potential pitfall of MDT is in patients with PSMA detected lymph node involvement. PSMA PET has poor accuracy in detection lymph node involvements, and Professor Stanzel mentioned that in his lecture. And patients who have 1 to 2 lymph nodes appearing on PSMA PET-CT may actually harbor further disease, and for them, targeted therapy with MDT for those lesions can only represent under treatment in that setting. Here are some available phase 2 single-arm prospective trials for this kind of treatment, and as you can see, there are promising results in terms of local and distant free survival and biochemical disease-free survival. Patient selection is very important, and you choose patient with a lower metastatic burden. You have to know precise place of metastasis using right imaging, and using MDT. The idea is to prolong introduction of androgen deprivation therapy. There are 2 important trials which I'm about to remind you of. Compare SBRT and surgery versus observation, and in both studies we have a good PSA response. The important thing to emphasize is that MDT is connected with a low toxicity, and on the other hand, immediate androgen deprivation therapy is sometimes expensive, and it can lead to potential decline in quality of life. Those are Stamp and Oriole studies. You probably know about them. The first one is Belgian one. They recruited patients in 6 Belgian institutions, and criteria met by eligible patients included pathologically confirmed prostate cancer treated with curative intent, either radical prostatectomy, either radiotherapy, followed by PSA relapse up to 3 extracranial metastases, and the negative multiparametric magnetic resonance imaging or negative biopsy at prostate bed. So patients with just a second, I'm sorry. Anyhow, a subgroup analysis showed that the comparable benefit with MDT for patients with nodal and non-nodal metastasis, and the retrospective data suggested that patients with a PSA doubling time shorter than 3 months had a shorter time to progression-free survival with MDT than did patients with a longer doubling time. And from their data, it seems that the magnitude of benefit with MDT as compared with surveillance is greater for those patients with a shorter PSA doubling time. And consequently, there is no rationale to decline MDT for patients with a shorter PSA doubling time. Currently, there are no data which suggest an improvement in overall survival, and two comprehensive reviews highlighted MDT as a promising therapeutic approach that must still be considered as investigational until the results of ongoing trials are available. And the toxicity of MDT appears to be low, but this also needs to be confirmed. Phase 2 trials indicate that metastasis-directed therapy is feasible, well-tolerated, improves biochemical response and progression-free survival compared to observation, and metastasis-directed therapy in other tumor types have demonstrated an improvement in overall survival, and metastasis-directed therapy should not be considered the standard of care based on a phase 2 trials. This here is one interesting case of one patient who showed up in my ambulance, and he brought me this document. This is a history of his disease. I'm not sure that you can see properly, but I will explain you in a couple words. He actually underwent radical surgery in 2018. And in a short while after operation, PSA level started to rise. So he went to AKH, did the PSMA PET, and after that he underwent 3 stereotactic treatment in a clinical center of Serbia. It's not conventional therapy. Actually, I'm not sure how this even happened, but he had tremendous oncological result in terms of delaying introduction of androgen deprivation therapy, and he also preserved good quality of life. Salvage lymphadenectomy is something which I'm more familiar with, and I prefer it since that's our job to operate. And we have some experience with these operations, but the thing is that we don't have PSMA PET in Belgrade, so only patients that can afford this kind of diagnosis in Austria, for example, could be candidates for operation. This study here is also interesting. They included 840 patients who experienced PSA rise in nodal recurrence after radical prostatectomy and underwent salvage lymphadenectomy at 9 tertiary referral centers by expert surgeons between 2002 and 2016. And the results are almost comparable to results of STAMP trial in terms of delay of introduction of androgen deprivation therapy. It seems that this kind of therapy, they didn't have a good control group here, but it looks like the majority of patients really had a good result in terms of delaying of androgen deprivation therapy. Also, is important to emphasize the economical fact that, for example, this trial-based cost-utility study suggests that MDT is potentially cost-effective in the treatment of oligorecurrent prostate cancer patients compared to surveillance with delayed androgen therapy and even to immediate androgen deprivation therapy. However, this analysis was based on the results of STAN trial, which had a phase 2 design. But nevertheless, this study suggests a health economic advantage of MDT and supports ongoing phase 3 studies to confirm its efficiency. In conclusion, this therapy is, that's obvious, associated with low toxicity and rates on in-field recurrence. And the main endpoint is to decrease cancer progression. Of course, patient selection is mandatory, and strong phase 3 data are yet to be published, but combination therapy is likely the key. Thank you for your attention.
Thank you, Dr. Babić, for a very informative presentation. It's time to discussion. We have about 10 minutes. It's open